The first speaker is Tena. Tiruneh. Did I get that right? Really? Should keep my glasses lost, I guess. And Tena is Director of Community Health and Laboratory Programs with Heart to Heart International. And um, I guess it's one speaker at a time that I should announce. So welcome.
Good afternoon. Thank you for the invitation. I came here thinking I was going to present, but I can tell you since this morning, my creative side is going, wow, I'm so glad I did get a chance to come here and learn. Thank you so much. I've learned a lot, and I'm hoping there's ways we can take the lessons and implement in the space that we work in. So my name is Tena. I am, yes, the Community Health Program Director at Heart to Heart. My background is laboratory science. I've had the opportunity to manage a few laboratories across 4 different industries, diagnostics, reference, hospital labs, and I'm now giving back, if you can say that, using some of my skills in that space to extend laboratory testing capacities and capabilities around the world. We also have a domestic actual program in the free and charitable clinic space where we try to provide point of care testing, which is the lowest level of testing you can do in a regulated industry for those homeless or houseless patients that the free and charitable clinics serve in the U.S. so that they can actually have some sort of testing done before they leave the premises because you won't get them back in order to be able to diagnose and treat. So we've got both programs at Heart to Heart that I get to manage and enjoy. This picture right here that you see, the presentation today, by the way, I'm going to be focusing on is the laboratory information systems or software installation that we're doing in the African continent with several partners. Now imagine going back in time, I think in the US, I'm also an immigrant. I got here about the 80s, but in the 1970s, that's when initially laboratories from the testing all the way to trying to integrate the data from the instrument all the way to the medical records, that, that area or space of work began around the 1970s. So even in the US prior to that, it was somebody sitting at right by the instrument doing data entry on a computer to feed the data into the EMR so that the physician could see it at the bench side or at the bedside in order to make a decision. So beyond that, that was in the 70s, which is what, 58 years, 54 years ago. Today in the African context, they're still in paper mode. And I think somebody was talking about surveys earlier as to going out and writing in paper and wondering what happens. So this particular one we installed last year. This hospital, as you can see, is a tier health facility, which means it's almost the top level of laboratory services being provided in Nigeria. This is in Nigeria. It is one of the top hospitals, and it is one of the biggest. And West Africa is really well advanced in the context of Africa, as most of you know, because you do work there. So you can see here that they have about 2,892 full-time staff. It's a really big hospital with that many academic departments being tended to, 49,000 students enrolled, and about 500,000 graduates doing a lot of work around the world, obviously, and about 10,000 annual patient turnovers. That means within 3 to 5 days, the 1,000-bed hospital is turning over patients. You've been admitted, 3 to 5 days later, you're being sent out. So within about a month, they are already overturning 10,000 patients in that hospital. What happens when you come into a hospital? Your blood is drawn almost every morning and again maybe later during the day so that the physicians could see how you're doing with the treatments they're providing to you while you're in the hospital. Imagine a phlebotomist going up there, and I don't even know how many they have, drawing blood and bringing it down to a lab, and somebody standing there trying to make sure that they don't make an error and actually write the right number and then give results of the right tube and then somehow accumulate that data in paper form in a folder and take it upstairs to a nurse that's responsible for a ward that has probably 20 to 30 beds. And that nurse is going to figure out how to take that single paper and make sure it's in the correct patient's record so that the physician that's doing the round actually gets to see that and make a decision, all in paper. And please do not ask what the person's result was last week. I don't even know how they do it. And then if you're that person that's actually responsible for grabbing all those folders, walking upstairs, maybe, I don't know, stairs, maybe an elevator, and I hope a little piece of paper doesn't slip out and fall. And I'm not sure what the rules are on HIPAA in that context, right? So this is the challenge that we saw when we were there trying to figure out what we need to do. So that we do provide the software now that we've installed in this clinic, where the instrument now directly uploads results into the EMR, and the physicians can make informed decisions very quickly. There are 3 steps to this was. Initially, obviously, is assessment. The second is installation. And then the third is post-installment evaluations. Installations, as you can see, surveys, as you can see, takes us about 5 days. So it's not momentous, but the impact is huge. Just about 5 days, we were able to assess a hospital of that magnitude very quickly to see what they would need in terms of computers, barcodes, all of those things that would be needed to make sure that, and the type of instrument they're using and the interface that would have to be done in order for, is it compatible to the software? Is it going to be compatible to the EMR that hospital is running? Do they have enough staff? What is the competency of the IT group? Do they have network capacity? Is the power source able to, right? Once you put it electronic and then there's no sustainable power, they're going to go right back to paper and they're probably going to hate you. And they're probably not going to go back because they see it's inconsistent. So we do all of that evaluation, and then, of course, we send them pre-questionnaires. I mean, I think you all know that, so that we have some data from them initially to go cross-check and make sure. So we talk to leadership, we talk to focus groups, we talk to IT personnel, and we confirm all of the expectations based on the survey results they gave us. Now, I can tell you the toughest part is gaining chief medical or decision-making support, because the cultural realities there is that a physician is like God. And they want to be the ones that say, yes, this result is okay, and it can go on. And to make that electronic, it's such a huge cultural shift for them that they're very resistant to accepting this particular, in my mind, simple change, but in them, it does impact the hierarchy of how the culture runs in that particular place. So those are the challenges we've had to work through. Installation is about 3 weeks. We do have technologists that are trained in the software that live in those countries. Like in this particular case, one of the gentlemen that installed was from Nigeria. He's being trained. He's done it for several years in many, many other countries. We add additional staff if we need to, based on the workload. There are about 3 of them that can go to different countries to be able to install these. And then we do hands-on training to the staff and troubleshooting training as well. The biggest difficult area here is really the networking knowledge, not the software utilization or not the software, the crux of the software. It's really networking is the area of deficiency that we find, and IT network expertise is something that we do have training and other developments that come alongside it, but it's really the area we see some weaknesses in. Lastly, the post, or what happens after the installations. There's another visit that we go through to make sure that things are running well. Additional training will be identified at that time, and we'll provide additional training. And then 3 months later, we'll do a remote technical visit as well as continuous support. And I can tell you, overall in this particular collaboration, over 20 LIS installations have already been done and have shown great success. turnaround time has gone from 10 to 20 days to 3 days, where results are now readily available. Error rates have dropped. Data entry errors are a thing of the past, and it's really making a difference. And I'm hoping that we can scale this. We're getting very close to knowing what it would take to scale. We know the cost of it, the input and the training and the ongoing continuing monitoring, to where we'll be able to tell better stories in order to be able to scale this up. And again, we do other activities within Heart to Heart in this space, but this one I thought would fit more in the digital meeting that you all have hosted today. So thank you for having us, and I'll turn it over to the next speaker.